Okay, everybody, now we are going into part two. Remember, part one had more to do about fluid, talking a little bit more about water volume from the intra and extracellular. We're going to start talking about electrolytes, and I don't want students to be confused, but when we're talking about patient care, we are really focusing on the extracellular fluid. That is what we can draw from. That's where we can get our lab values from. So you have to really focus on that to have a better understanding why it's important, because that is what's available to the body to use at the time that it's needed. So let's go ahead and dive right in. The first one we're going to talk about is sodium. It's the most abundant electrolyte in the ECF. The range is 136 to 145. You need to know your lab values. It plays a major role in controlling water in the body. It's regulated by ADH, thirst mechanism, and the renin-angiotensin-aldosterone system, or the RAS system. Make sure that you understand some common food sources in which an individual could obtain sodium from. And plus two, remember, sodium is known as a cation. I like this little visual here, and it's an ion with a positive charge, and it is the cutest ion ever. When we're talking about electrolyte imbalances, the first one we're going to talk about, and this is your snapshot, is hyponatremia. I put some emphasis here, so when you are reading test questions, make sure you know what electrolyte you're dealing with. It's going to be values less than 136. It can be caused by active losses or by dilutional hyponatremia. Clinical manifestations really depend on the cause, the magnitude, and how fast the deficit happens. It may necessitate fluid restriction or sodium replacement. In terms of nursing care, you want to watch the fluid I's and O's, daily body weights, and central nervous system changes. So this gives another breakdown again about hyponatremia. Again, know your lab values less than 136. You will typically see a decrease here in specific gravity. This could happen with an increased sodium excretion when too much sodium is leaving the body. This can happen through excessive diaphoresis, use of diuretics, vomiting, diarrhea, wound drainage, in particular with the GI, renal disease, and a decreased secretion of aldosterone. It can also happen because a person is not taking in enough sodium. So if a patient's been NPO, or if they're on a low salt diet. Other things to consider is a dilution of serum sodium. So this can happen through water intoxication. It can happen through ingestion of hypotonic fluids or irrigation with hypotonic fluids, renal failure, syndrome of inappropriate antidiuretic hormone secretion, also known as SIADH, which you will learn more in depth during endocrine, hyperglycemia, or with congestive heart failure. Signs and symptoms of hyponatremia vary depending on the severity. Everything from stupor to coma, anorexia with nausea and vomiting, lethargy. Tendon reflexes tend to be decreased, limb muscle weakness, orthostatic hypotension, seizure and headache, and stomach cramping. So mnemonic for signs and symptoms for hyponatremia. We have salt loss. And here are some different ways that salt loss can happen. GI suctioning, diarrhea, inadequate salt intake, fluid shift, diuretics, and vomiting. So these are some good visuals to take a look at when you are trying to learn the different signs and symptoms. Treatment for hyponatremia will really vary based on the symptoms. You don't want to replace the sodium too quickly because it can actually cause seizures. If a patient has fluid volume excess, you will need to restrict fluids and promote diuresis. If it is caused by a fluid volume deficit, you need to replace the fluids along with the sodium. Typically, hyponatremia will be treated with either hypertonic or isotonic solution. The main ways that people lose sodium are going to be through vomiting, through GI suctioning, and diarrhea. Hypertonic solutions in particular should really only be done for severe hyponatremia and done in the ICU setting. Isotonic fluids typically are more reasonable to be used. Because of this, patients should be on seizure precautions, and you will want to monitor their eyes and nose. When we talk about hyponatremia, because it's dilutional, it's going to be typically of water intoxication, heart failure, renal failure, or cirrhosis. Normally, the signs and symptoms you're going to see with dilutional are going to be confusion, weight gain, and edema. Make sure you watch the person's eyes and nose and restrict their fluid intake. Now on the flip side, we're going to talk about hypernatremia. The snapshot of this is basically when sodium exceeds 145 milliquil per liter, caused by a gain of sodium in excess of water or by a loss of water. Clinical manifestations are primary neurologic. Treatment is usually a hypotonic electrolyte solution, and nursing care focuses on prevention and on close monitoring of fluid, eyes, and nose. So again, hypernatremia is when the lab values are greater than 145. You'll see an increased urine-specific gravity with hypernatremia. It can happen due to decreased sodium excretion. There's not enough sodium leaving the body. This can happen due to corticosteroid use, Cushing's disease, hyperaldosteronism, and renal failure. It can also happen by excessive sodium intake. It may also happen by decreased water intake. This could be an unconscious patient who cannot perceive or respond to or communicate thirst, the very old, the very young, or those who are cognitively impaired. It can happen due to increased water loss, by fever, hyperventilation, excessive diaphoresis, watery diarrhea, diabetes insipidus, or with an increased metabolic rate. But typically, it may be due to a cause of excessive sodium intake. Mnemonics, again, for those who like them, is model. Can be medications, osmotic diuretics, diabetes insipidus, excessive water loss, and low water intake. Mnemonic for signs and symptoms for hypernatremia is fried salt. In particular, you're going to see thirst, rough, dry tongue, dry membranes, flushed skin, oliguria, and low-grade fever typically with these patients. Watch their I's and O's. Solutions typically can be hypotonic used to treat or isotonic. It depends on the severity. Medical isotonic non-saline solutions like D5W or hypotonic fluid. Watch their I's and O's. Watch behavioral changes and promote fluid intake. If you have a patient who is tube feeding, you'll want to talk to a nutritionist about free water to be used. Now we're going to move on to potassium. And potassium is going to be very vital almost in every thing we're going to talk about for the remainder of the semester will have something to do about potassium. So make sure that you're well aware about potassium in the body because it does have a significant effect on the body. It is the most abundant electrolyte in the ICF, so the intracellular, 98% of potassium exists in the cells. If you look at what is available in the extracellular, is only 3.5 to 5.0 milliquil per liter in the extracellular. So if you go back and you think what sodium was, there's more sodium in the extracellular than there is potassium. But potassium plays a major role in neuromuscular function. It is regulated by the kidneys, particularly aldosterone. And make sure you know some common food sources for potassium. The first electrolyte imbalance we're going to talk about with potassium is hypokalemia. Again, make sure when you're reading your test questions what electrolyte imbalance you're dealing with. Potassium levels of less than 3.5 milliquil from active losses of potassium or insufficient intake. Hypokalemia is going to be more common than hyperkalemia. You'll see cardiac, respiratory, and muscular manifestations because, again, it affects the neuromuscular functions of the body. So it's just not the heart, but think of other major muscles that are important for bodily functions, like respiratory and muscles. So not only is looking at a person's EKG important, but also looking at their respiratory rate. Treatment is oral or IV replacement therapy. Nursing treatments focus on the assessment of cardiac and motor signs and symptoms. When we look at the causes, it can be lost from the body through diuretics, diarrhea, vomiting, gastric suctioning, recent ileostomy, intestinal drains, and villus adenoma. Decrease input if a person's NPO, anorexia, vomiting, alcoholism, and fasting diets. Movement from the ECF into the cell through metabolic alkalosis or insulin use. Or it can be due to dilution through water intoxication. Those who are visuals, here are some mnemonics for signs and symptoms. Just take some time. You can use either one of them. It's a sick walt. So when we talk about hypokalemia in the heart, so when we look at an ECG or EKG, changes will include a flat T wave or inverted T wave or both, suggesting ischemia and depressed ST segments. Also, an elevated U wave is specific to hypokalemia. So for testing purposes, make sure you know how potassium affects the heart in terms of EKG readings. Hypokalemia management, we need to replace it. If we're going to do it by mouth, it's going to be encouraging potassium-rich foods. And here's a good list for you. Potassium supplements. So if they come in pill form, it's okay to score, but not to crush or to chew a potassium pill. So okay to score, but not to crush or chew. It can also come in a liquid form, which is also known as an elixir. It tastes awful, so it's best to mix it with something like juice. Also know that oral potassium supplements can produce small bowel lesions. Therefore, the patient must be assessed and taken caution about abdominal distension, pain, or GI bleeding. Now, replacing potassium by IV, it burns. So if a patient complains about it burning, you want to either have it diluted or slow down the rate. Make sure you use an IV pump. No more than 20 milliquils per 100 mLs in a peripheral IV. No faster than 10 to 20 milliquils per hour. And it can cause phlebitis, so IV sites need to be assessed. And never, ever, ever give potassium by IV push unless you want to kill your patient. So there's a lot of points here you need to know, all for testing purposes. So the nurse suspects that a patient who is receiving NG suction has hypokalemia. What manifestations should the nurse expect this patient to exhibit? Increased bowel motility, ECG changes, increased muscle strength, or agitation. We're going to see ECG or EKG changes with hypokalemia that can include a flat T wave or inverted T wave or both, suggesting ischemia, and depressed ST segments. Decreased bowel motility, fatigue, and weakness may also accompany the problem. So when you're looking at some EKG in terms of hypokalemia, you notice that everything is flat or inverted or depressed. So those are some good words to think of when you're looking at an EKG in terms of hypokalemia. On the flip side, when we talk about hyperkalemia or elevated potassium, it's going to be levels greater than 5 milliquil per liter, resulting from increased intake, medications, musculoskeletal injury, decreased renal excretion of potassium. There can be significant cardiac and GI manifestations. Treatment involves potassium restriction and/or medications, and the nurse needs to observe signs of muscle weakness and arrhythmias. Causes: intake of medications. We're looking at salt substitutes, potassium supplements, penicillin K or K-sparing diuretics such as spironolactone and ACE inhibitors, decrease output, renal disease, hypoaldosteronism. When there is cell injury like crushing injuries, burns, trauma, intravascular hemolysis, or rhabdomyolysis, and chemotherapy will actually push potassium from inside the cells to the extracellular. Also, metabolic acidosis will shift potassium from the cells to the extracellular fluid. Here are those signs and symptoms, the mnemonics for our visual learners. Murder, muscle cramps, urine abnormalities, respiratory distress, decreased cardiac contractility, EKG changes, and reflexes. Again, remember that potassium affects the muscular neural systems in the body. So when we talk about hyperkalemia in the heart, EKG or ECGs will show peaked narrow T waves, ST segment depression, and a shortened QT interval. Typically, you'll see changes with values of 6 milliquil or greater. Again, make sure you know with hyperkalemia that you'll see those peak T waves. So managing hyperkalemia is going to be about ridding the body of it. Know that the severity is going to be mild, moderate, or severe. So levels above 6 is going to be considered severe. Piorectal K-oxalate will actually bind to potassium within the bowel and excreting it within the stool. Problem with using K-oxalate is that there's a risk of bowel ischemia with it. K-oxalate, one way to think of it is you poop the K out. Another is Veltessa that actually binds to the potassium in the GI tract. But remember, when we're thinking about hyperkalemia and wanting to reduce it, a lot of it's going to have to do about speed. So knowing that if somebody's going to take something by mouth, it's not going to happen very quickly. Inhaled, sometimes they may use a beta-2 agonist like albuterol. Large doses are needed to actually elicit any type of potassium shifting into the cells. Big warning with this that it can cause tachycardia, so caution with those with ischemic cardiac disease. Typically, we're going to use IV route. You can use sodium bicarbonate. Usually works in 30 to 60 minutes, and it's temporary. Calcium glutamate is also another temporary measure. Another way is to use regular insulin in a hypertonic dextrose solution. Again, it works typically within 30 minutes, and it is also a temporary fix. For patients that loop diuretics can be used, furosemide or Lasix will increase the excretion of water by inhibiting sodium, potassium, and chloride reabsorption in the ascending loop of Henle and the distal renal tubules. And another means can be through dialysis. But a lot of times we use your loop diuretics. So management long-term for those who are prone to having high potassium levels, you've got to talk to patients about avoiding potassium-rich foods. Many fruits and vegetables, legumes, whole grain breads, meats, eggs, and coffee and tea and cocoa can be high. Almost everything is high in potassium or has some amount of potassium in it. And not to get thrown off, but you want to make sure that these patients avoid salt substitutes. And I'll talk a little bit more in class about them, but salt substitutes actually are high in potassium. It kind of tastes like salt, but it's not salt. And it's not the same thing as something like Mrs. Dash, because Mrs. Dash doesn't have any salt in it, but is other herbs. But a salt substitute kind of tastes like salt, but it's very high in potassium. You want to encourage foods that have lower potassium contents in them, and medications, avoid potassium conserving diuretics like spilactone and potassium supplements. So right now we're about halfway through this presentation. We're at about 24 minutes. So I would really advise you to take a moment to relax, refresh, get recharged before we go into the other electrolytes. All right, so I hope most of you went ahead and took a little break, potty break, drink break, some sort before we jump into the rest of these slides. So now we're going to talk about calcium. It is the most abundant in the skeletal system. 99% of it resides there. In the extracellular, there is 9.0 to 10.5 milligrams per dl. It plays a role in cardiac conduction, nerve impulses, activating enzymes, and blood clotting. It is regulated by the PTH and calcitonin. And make sure you know some calcium-rich foods. So a snapshot when we're talking about hypocalcemia, and again, for testing purposes, make sure you know what electrolyte imbalance you're dealing with. It's going to be levels less than 9.0. It can be from inadequate intake, increased loss, malabsorption, or increased binding of calcium. It can result in tetany, and it will require IV administration of calcium. So causes for low calcium really vary, and so it's going to be really important to take a good patient history when we're talking about hypocalcemia. It can be a result of decreased intake of medications. You look here, it can be associated with chronic alcoholism, malnutrition, antacids, or using aluminum-containing antacids, certain anticonvulsives, corticosteroids, loop diuretics, gland dysfunction, hypoparathyroidism, which I will tell you right now when we get into endocrine, just see them as synonymous. Hypoparathyroidism will be synonymous with hypocalcemia, so hypo. Other parathyroid gland disorders, surgery of the thyroid gland, which accidentally removes part of the parathyroid, radiation injury to the thyroid, and radial neck dissection. Increased loss can be associated with pancreatic insufficiency and acute pancreatitis. It's also associated with metabolic alkalosis. It causes calcium to bind to proteins. It can happen through malabsorption, severe diarrhea, laxative abuse, decreased exposure to sunlight, or conditions that impair vitamin D. High phosphorus levels in the intestines reduce gastric acidity and kidney failure. So when we are talking about management of hypocalcemia, like others, anytime it's low, we want to replace it. We want to put a patient on a cardiac monitor if they are critical, if levels are less than 7.5. Maintain their airway. Risk for laryngeal stridor if it is critical. Replace using calcium supplements. Monitor the EKG changes. Observe for infiltration of the IV. Monitor for hypercalcemia. And make sure you warm the solution prior. IV replacement, keep the patient in bed. They're at risk for postural hypertension. You want to administer medications that will increase calcium. Things like aluminum hydroxide or Melanta will lower phosphorus, thereby increasing calcium levels. And vitamin D will aid in the calcium absorption from the GI tract. Give the patient a quiet environment. Initiate seizure precautions. Educate about healthy lifestyles, calcium-rich foods, weight-bearing exercise, get them to stop smoking, and decrease alcohol and caffeine intake, because it will rob the body of calcium. When we talk about hypercalcemia, these are going to be levels greater than 10.5, usually resulting from a malignancy or hyperparathyroidism. So again, like I said before, with hypocalcemia, with hypoparathyroidism, hypercalcemia will be synonymous with hyperparathyroidism. It can result in weakness and cardiovascular effects. Treatment is diuresis and management of the underlying cause. Causes of hypercalcemia can be from medications and supplements, thiazide diuretics, vitamin A and D intoxication, and lithium. Can be from immobilization. When a person doesn't move, they don't have that weight-bearing activity to help push the calcium back into the intracellular, so it will stay in the extracellular, and it will result in bone mineral loss. Malignancy or gland dysfunction can result from cancer or tumors and hyperparathyroidism. It can also be caused by something called milk alkali syndrome, which is rare, and that occurs in patients with peptic ulcers treated for a prolonged period with milk and alkaline and acids, particularly calcium carbonate. Mnemonics from hypercalcemia will be back me, bone pain, arrhythmia, cardiac arrest, kidney stones, muscle weakness, and excessive urination. Another mnemonic is bones, stones, groans, and moans. Painful bones can cause a painful bone condition. Kidney stones. GI symptoms is the abdominal groans like nausea, vomiting, constipation, and indigestion. And the bones refer to more psychiatric, lethargy, fatigue, memory loss, psychosis, and depression. Management: put the person on a cardiac monitor. Discontinue any mouth or IV calcium and vitamin D. Discontinue thiazide diuretics. Initiate diuretics which promote excretion of potassium, like a loop diuretic, which would be furosemide. Possible dialysis if the levels are too high and it's not corrected through medicine. Encourage mobility and fluid intake with sodium. And instruct to avoid foods high in calcium. The nurse is caring for a patient who is in renal failure. During shift assessment, the patient complains of tingling in her lips and fingers whenever anyone takes her blood pressure. She claims that she gets a spasm in her wrist and hand, and that's very painful. What would the nurse suspect? Hopefully you said hypocalcemia. Tetany is the most characteristic manifestation of hypocalcemia and hypomagnesia. Sensations of tingling may occur in the tips of the fingers, around the mouth, and less commonly in the feet. Hypernatremia and hyperkalemia are not associated with these signs and symptoms. Magnesium imbalances, you won't see this as often, but should still be aware of it. Know your normal serum magnesium levels are 1.3 to 2.3. Magnesium is an activator for many intracellular enzyme systems and plays a role in both carbohydrate and protein metabolism. Hypomagnesia often results from alcoholism or GI losses. Neuromuscular symptoms are treated with magnesium salts. And hypermagnesium or magnesia is rare and is usually caused by renal failure. So side by side, hypomagnesia, alcoholism is the major cause. Signs and symptoms, cardiac dysrhythmias, EKG changes. Troussage de pointe is typically what is seen in terms of dysrhythmia. Hypermagnesia, again, it's going to be rare. Usually the major cause is going to be renal failure. Phosphorus imbalances, know your ranges, 2.5 to 4.5. Phosphorus is needed for a lot of physiological processes. Hypophosphatemia is a result from the use of nutritional supplements. Usually you see neurological and muscular symptoms. Hyperphosphatemia will result from renal failure, and usually symptoms are asymptomatic, and it's all going to be about treating the underlying disorder. Chloride imbalances is a major anion in the ECF. Levels are typically 97 to 107. Low chloride in the body is usually rare, and it's in the absence of other abnormalities. Signs are typically associated with hyponatremia, hypokalemia, and metabolic alkalinosis. A lot of times the treatment will involve correcting the cause. Hyperchloridemia is related to hypernatremia, bicarbonate loss, and metabolic acidosis. And again, this will be more about restoring electrolyte, fluid, and acid-base balance. So you'll see more of this having to do with metabolic disorders. Last thing I just want to touch, you folks have already had a quiz that talked about this, but I want to make sure that you understand why you must do frequent assessment of your IV sites. You will see questions about IVs, and make sure that you're clear on what the different issues are. So make sure you know what it is, what you should observe, what you would need to do, and also how you would actually rate the severity of it. If you have any questions, again, the 3 that you should really focus on will be your potassium, your sodium, your calcium, your other electrolytes. Just have some basic knowledge of them, and you should do all right.